Thank you for giving me this opportunity, all the Salvas, TP Lane sir, Sonu Goyal sir, Kudlu sir, and AIOS team. So I'm just going to show an algorithm on how you choose a refractive procedure, but I'll not go into depth of how to do it, when to do it, because I'm sure other speakers are going to cover it. I have no financial disclosures or anything interest in related to this procedure. So we have an increased, with every year there are increased numbers of refractive procedures which happen, and also along with the procedures which are increasing, even our options are also becoming broader and broader. So it becomes like, initially like 10 years, 12 years back, it was very much clear. The patient comes, you do a LASIK surgery, it was mostly an aberration free or a wavefront optimized procedure. But now the patient expectations are increasing, the numbers are increasing, our options are also increasing. So what is the best procedure for our patients? It is our duty to customize the procedure for the patient and give the best outcomes for the patient. So preoperative evaluation, we all know it will include the manifest and cycloplegic refraction, slit lamp evaluation, your corneal topography. You will also see whether the lens is normal. There should not be any higher internal aberrations, because if there is any higher internal aberrations and you do a LASIK procedure, of course you will land up into a post-op unhappy patient. If you're doing a presbyopic surgery, you do a tolerance test or monovision, which Kuddu sir I'm sure is going to explain very nicely. You do the nominant eye for our reference. A dilated fundoscopy is must. It is also must to see the pupil size, the scotopic and the mesopic pupil size, because based on that you can decide your optical and the ablation zone for the patient. If the patient has been a chronic contact lens user, you need to discontinue it for at least a week to 2 based on the type of contact lenses they wear. Do a dry evaluation for all your patients. If you find any any issues with squint or something, do a strabismus assessment, and ability to tolerate as anisometropia should also be checked wherever necessary. So based on all this examination, the examination we all know and we all are crystal clear on it. But then which approach do we choose? Which type of procedure do we choose? That, like, we know there are various publications on comparison of procedures and type, but there is no straightforward algorithm on how to choose. So what do we do? This is just based on experience and literature, nothing to do personally. So a simple algorithm: if the patient has age less than 40 years, you see the type of the cylinder. If cylinder is less than point and the corneal aberrations, all your modern day topographers gives you aberrations, so you don't need to worry about it. If the aberrations are on the lower side, your mesopic pupil size is less than 6 millimeter, the topography and pachymetry are normal. If the patient has a history of contact sport, you go ahead and do a smile. If the patient has no history of contact sport, if the cylinder is less than 0.75 dioptric cylinder, you can go ahead and do a wavefront optimized treatment or an aberration-free treatment. These are just the machines which give you those options. If I miss something, it is just this one, not intentional. If the patient has any higher corneal order aberrations, or if the corneal cylinder is more than if the cylinder patient acceptance cylinder is more than 0.75, you go ahead with a topo guided treatment. But if the patient acceptance cylinder is more than the corneal cylinder, then you would go ahead and do a wavefront guided treatment for these patients. The next would be if your patients are ametropic, but not suitable for excimer laser surgery. If the conditions would be if the RSB is going less than 300 microns, or any other condition, a suspicious topography or a weak biomechanics, etc. If your ACD is more than 2.8 and if your endothelial cell count is good, you can choose a phakic IOL for this patients. But if the corneal thickness is more than 475 but less than 500, and if there is any flat or steep thing or subtle topography irregularities, or if the refractive error is less than 6 diopters, or if there is a contact sport, you would go ahead and do a PRK or a trans PRK for this patient. If the patient is more than 40 years, you do a tolerance test for this patient, a contact lens trial. You check for internal aberrations. If everything is normal, you can go ahead and do a presbyopia LASIK surgery for this patient, depending on the machine and the principle they have. But if the internal aberrations, like your dysfunctional lens index, even if the lens is normal, but your nuclear staging is on the pentacam is higher, or the dysfunctional lens index is on the higher side, you would not do any kind of LASIK surgery or a presbyopia LASIK surgery. You would go ahead and do a refractive lens exchange for this patient. And based on their, if to choose multifocal IOL or not, you see the pupil size, you see the higher order aberrations, you see the angle alpha, and if the retinal evaluation is normal, then you go ahead with a multifocal IOL. If it is abnormal, then you would only choose a monofocal IOL for this patient.